we are truly thankful, Dr. Reddy, there for making space for us. And she needs no introduction. She's the chief of the Cornea Refractive Services at Arvind Eye Care Systems based at Coimbatore, a very admired surgeon nationally and internationally. And she's going to take us on to relevance and importance of PK in today's practice. On to you.
Thank you, Dr. Chitra, and also my co-speakers who readily accommodated my request. So this topic is about the PK. Is it relevant even now where the lamellar surgeries are taking over? And they have definite advantage in preserving globe integrity, and many problems with the sutures and others can be foregone, and also faster recovery with less complications. But why we need PKP even in this era? Because there are certain situations where PKP will be the saver. For example, in case of scar, which is a full thickness one, and also even post trauma also, where not only the scar, the visual corneal contour itself is compromised badly. And in case of dystrophies, where a combined anterior and posterior dystrophies, and in case of failed grafts, where we need to do this failed grafts, even still we can do a posterior keratoplasty, but still sometimes we may need to go for a PKP. And also in case of corneal decompensation with a compromised iris lens diaphragm, like in case of ICE or an aphakic eye or secondary IOL with a vitrectomized eye, in those cases, of course, it's quite true that whoever has seen Dr. Fogla's pictures, beautiful pictures in Keranet few days back in a post tube case, ICE will be, the hands will be itching to wait for next ICE to go for a EK only, a DSEC. But of course, for the beginners, we have to be very careful. If unless you are very well versed and you are very confident about your this thing, and also keep a cornea as a backup. At any time, you should be able to convert. Then you go for such heroic surgeries. And of course, it can be done, but of course, PK has a role in such cases. Coming to the dystrophies, in case of anterior and posterior, we can go for a ALK or EK. But in case of dystrophies like MCD, it's quite difficult to assess the depth because it can go up to the Duas layer. And you may need to, if you want to get a clear interface here, you may need to intentionally create a type 2 bubble here. And which is technically very difficult, and it can fail at, it can go for perforation or big tear where you have to convert. And another thing, if you are not able to remove all the material, then the recurrence may be faster in these cases. And remember, MCD can be associated with endothelial changes also. So in these cases, better to plan as a keep and PKP great cornea and try, but if necessary, you have to convert to PKP. In case of other posterior dystrophies like CHED, it again, the removal of the endothelium may be very quite difficult. And if the cornea is too thick, again, just a DMEC or DSEC sometimes may fail. So you may need to convert them later to PKP, or if it is too thick, better to plan as a PKP. In case of regrafts, the graft, not only the opacity of the graft, if the graft is grossly decentered, then you may not get a very good, as Dr. Vanathi put it, you may end up with, even after a good DSEC, you may end up with a very bad, ugly astigmatism. So it's better to plan for a regraft, well-centered, good PKP. And in case of post-hydrops, of course, if the scar is only in the posterior level, still you can attempt DALK, but if it is a full thickness, very bad hydrops, not managed properly or spontaneously resolved, we ended up with such a scar, then you may need to go for a PK only. In case of scars, we have to remember one thing, in either in microbial infections or viral keratitis or trauma. As in this case, you can achieve some kind of closure initially, but later you may need to replace this cornea with a full thickness graft only, where the contour is really compromised. In scar, we have to be very careful. especially if the patient comes with a scar and you don't know why that scar occurred, and you have to really probe into it, at what age he started getting this problem, because amblyopia could be a issue in that eye. And the depth of involvement, of course, you can use ASOCT. In presence of vascularization, thinning, lipid deposits, and associated ocular surface problems also have to be kept in mind in preparing these corneas. Especially the corneal sensation is also very, very important. In case of vascularization, we have to address it first, either with cauterization or nowadays luminar injection of mitomycin, which again we have to be very careful, and we have to take it with very cautiously only, and control the inflammation. And in case of superficial vessels, look for any limbal stem cell deficiency, address it first, and then go for your procedure. And corneal sensation is very, very important, especially if it is anesthetic cornea. You are going to get into big trouble, either dark or whatever it is. So you have to address this first and then plan for the surgery. If it is a scar due to the viral keratitis, you know the precautions. You have to cover it with oral antiviral also. And as a surgical intervention, like you have to remember, this is an open sky procedure, and you have to address, as I said, the ocular surface issues, and starting from the lid and other conjunctiva and cornea, and also the intraocular issues like a mobile IOL has to be removed, and you have to plan your secondary IOL, another scleral fixation or iris fixation IOL. All those things also you have to plan properly. Lot of imaging also you may need to do to plan your surgery. And remember, this is an open sky procedure. Some of the fellows may not, of course, fellows may be well versed with PK, but sometimes people, especially students, will get carried away. They think only lamellar keratoplasties are the keratoplasties. But when doing PK, we have to remember this is an open globe procedure where you need not only complete akinesia, you need to control the blood pressure, intraocular pressure, blood pressure of the patient, as well as blood pressure of the surgeon also. Many times, like we'll be really it's testing surgery, and the speculum should be without any pressure over the globe, and whenever necessary, use the scleral rings. And this is a very, very old video. I think this is a video by Dr. MS. I'm not very sure. So here, why I want to show this mainly, like when it is open, till you put the graft again and suture, get that 4 cardinal sutures. You have to take care of your palpitation also. And you need, this is the playtime where you need a complete akinesia and complete control. This is very important. And of course, astigmatism, as in the case of DALK, here also astigmatism is a question. And like Dr. MS used to tell, Dr. M. Srinivasan used to tell, if you know how to put good 10-1 nylon sutures in those days, ECCE, without creating much astigmatism, then you can do the keratoplasty by yourself. You don't need any training. But I don't think it is that easy. And of course, PKP is also, penetrating keratoplasty is also used in therapeutic grafts to remove deload the infection, and also in case of patch grafts and any perforations. Whenever you get a perforation, you can do this. The flip side, of course, the suture related problems, and the rejection is a major issue. In EK also there is rejection, but relatively very, very less. So these cases have aggressive follow-up and close follow-up and aggressive management. In conclusion, this is not a last art, still it has a lot of role, and the corneal surgeon, all corneal surgeons should be well versed in PK, because at any time you may need to convert also. So you have to be well versed in this procedure also. Thank you.
Thanks a lot, Dr. Revathi. On to you, Shreyas.
Thank you so much, madam. Very extensive talk. Truly showing why PK is necessary in so many different scenarios, and it's an extremely important art that all cornea surgeons should perfect. A quick question about, you were showing a lot of situations where combined surgeries may also be a necessity with PK. how do you go about deciding in some of the opaque corneas whether you're going to tackle the lens in the same sitting or whether you're going to do it in two separate sittings, and if so, any considerations regarding IUL calculations?
Yeah, of course, as you said, if we can use some of these imaging techniques to assess the lens status or something comfortably, then we may plan. But still, if it is completely opaque, then I would like to do only the corneal part where we can get a good corneal surface, where we can properly plan the IOL power calculation, and we can do the lens part later. That's how I would prefer, unless where I can see the lens, the opacity, or it is not in the center, it is towards the periphery, something like that.
Yes, ma'am. And at least initially, we were a lot of there was a talk about suture removal in penetrating keratoplasty versus lamellar, that you would do a little earlier in lamellar versus penetrating. Do you have any difference in your practice pattern, or do you treat both similarly?
I treat both similarly, even in dark, because actually in dark, actually I feel you may need to keep the switches even longer than in PK. Because in dark, it's tend to be like once you remove the switches early, if you are going for early switch removal, there will be some myopic shift, and also the astigmatism can be more. So I treat them both in the same way only.
Thank you, Dr. Revathi.